So let's go ahead and get started by looking at the 4 categories of tissues that we have. So we already know and discussed this briefly last time or the first class meeting, when we were discussing the levels of organization. So let me actually ask you guys, what is the most basic level of organization we have? Most basic level. Type it in your chat box, please. Even smaller than cellular. Before cellular, what do we have? The smallest, the least complex level of organization we have. They're molecules and atoms, but what is the general terminology we use to describe molecules and atoms and organelles? As a whole umbrella term, start with the C, chemical level, correct. And then that's where we talked about the 4 major groups of your organic molecules, right? We talked about carbohydrates, talked about proteins, we talked about lipids, and we talked about nucleic acids. Those are your 4 major groups of foods, basically. We went further and we talked about.
Good morning.
Good morning. Could you please mute, because we're in the middle of lecture. So we went farther and we went into the cellular level, which is the second level of organization, which is, we talked about the organelles inside the cell, we talked about the plasma membrane, and we talked about the nucleus. And that was the main lecture for us yesterday, last week. We now going to talk about the third level of organization, which is our tissue, which simply, as it explained here, it's multiple or a group of closely associated cells that are performing a related function and are similar in structure. So as you can see, if you say muscle tissue, which is the easiest one for me to describe, if you have let's say hundreds or thousands of skeletal muscle cells and we put them together, then I get a skeletal muscle tissue. If I have thousands of epithelial cells together, then I get a very specific type of epithelial tissue. So do keep those in mind as we go through this, that regardless of the name of the tissue that I'm giving you, each of those are made up of cells that are similar and they carry and perform a similar function within that tissue. So here's our 4 major groups of tissue that we have. These are epithelial tissue, connective tissue, muscle tissue, and nervous tissue. If I was to use one single word to describe what is the job of epithelial tissue, it would be covering. Now I can go and explain it more. Another way of describing it is protection. It does provide significant amount of protection for our tissues. Think about your skin. Basically your skin is many layers of epithelial cells stacked on top of each other. Connective tissue. As you go through this PowerPoint, you'll notice that connective tissue is really diverse. So within the connective tissue, I have things called areolar tissue. Blood is a connective tissue. Your bones are a connective tissue. Yes, they are. We have cartilage as a connective tissue. So the main way of describing the function of the connective tissue is support. They basically support the rest of the structures like your muscles or your organs to make sure that they can do their job. Muscle tissue is pretty self-explanatory. What do you do when you use your muscles? It creates movement, right? So think about the skeletal muscles. The easiest way to describe them is movement. And nerve tissue, right? Or nervous tissue. When you think about nervous tissue, what pops into your head? It should be what? What's the easiest way of saying that? When you think about nervous tissue, guys. Nerves, sensation, what part of your body, what organ in your body? Brain, correct. Brain and a spinal cord, actually. So these are the ones that basically control what you do, correct? That's the easiest way that you want to look at it. In the case of nervous system, even though the variation in the type of cells are limited, as we'll look at it, but they still have an extremely important function in our body. Any questions so far, guys? Awesome. Okay, so let's start with our epithelial tissue. So again, one way that we can describe epithelial tissue is just simply saying that it is responsible for, or in terms of function, I should say, it's covering your body. But then again, we have various types of epithelial tissue. So what is the job of each of these categories of epithelial tissue? They can they can play a role in protection. Like as I mentioned, your skin is a very good way of protecting your internal organs. Absorption, secretion, and ion transport. Think about when you sweat or when you release oil to the surface of your body. These are all identified as secretion. Your epithelial tissue also does absorption, which is when you look at your digestive system. What do? You bring in food that you ate into your blood. That's the process of absorption. Filtration. If I ask you what is filtration associated with, one major system that is associated with is your urinary system, which is basically the way your body is gonna clean the waste out of the system and basically allow you to pee it out. And then forms a slippery surface. This is also very visible when we look at our intestines, when the folds of the intestines rub against each other. You have it, the layer around the heart that allows the heart to rub against each other. Same thing around your lungs. So having these slippery surface basically limits the friction and allows the organs to function without damaging each other or damaging themselves. So let's take a look at the epithelial tissue first, guys. So the easiest way I want you guys to think about epithelial tissue is that universally they're going to have two part names, and you can see it here. They have what we call a first name and a last name. So what is the first name if we're identifying an epithelial tissue? It is always going to be identifying how many layers of cells are stacked on top of each other, okay? So if I have a single layer of cell, the only word that I'm going to use to describe it would be simple. If I have anything more than one layer, so it could be 2 layers, or it could be 20 layers, or 30 layers, it doesn't matter. If it's above one single layer, we're going to identify that as a stratified. So when we're identifying the epithelial tissue, we only have 2 options for your first name, either simple or stratified. For the last name, we have 3 options. And those 3 options come from what is the shape of your epithelial cell. If they're flat and super thin, we call them squamous cells. So they're kind of literally really, really thin. If, look at the name, guys, cuboidal. Cuboidal means what? They're shaped like a cube, right? So they're more square shaped. So they are as wide as they are tall. Again, basically a square. What about the word columnar? So when you think about a column, what do you think? Something being super long, right? So these cells are going to be super tall compared to when they are wide. And therefore, we call them columnar, or they're shaped like a column. So based on what I've told you guys so far, based on what you see right in front of you, how many type of epithelial can I create by looking at the options for the first name and the options for the last name, guys? Can you take a moment and type a number for me? The question is, if I'm looking at identifying epithelial tissue, how many can I create by combining my first name and my last name? Correct, 6 of them. So look at this, guys. If I put simple, what can I put the simple in front of? I can put it in front of a squamous, cuboidal, and columnar. So that gives me 3 options. Same thing, a stratified can go in front of a squamous, cuboidal, and columnar. So it gives me a total of 6 different types of epithelial tissue, which are basically going to be the common names of epithelia we're going to identify. Is this making sense so far? Is there any questions before we dive into the shape and what they actually do in our body? Please feel free to guys type in as I bring a concept, and I'll come back and I'll answer your question. Okay, awesome. Okay, so here is a picture of what these cells actually look like. So let me just close this page. So here is a single layer of cells. Again, notice that these cells are flat. So look at the thickness, they're pretty thin. And it's a single layer, right? Look at this picture. We have at least 4 layers of cells stacked on top of each other, making this the stratified tissue. And then the other option would be cube shape or cuboidal. And then columnar cells, which are basically long or elongated cells, and that's the name columnar. So if you're looking at this picture, here is how you come up with the name again. Simple squamous, simple cuboidal, simple columnar. And then we have what? A stratified squamous, stratified cuboidal, and a stratified columnar. So those are your 6 common categories of epithelial tissue. Now notice that down here I have a specific type that says pseudostratified, and it doesn't show, but it's basically saying pseudostratified columnar. What do you think that means, guys? Can anybody understand what the word pseudo means? Anybody knows what the word pseudo means? Fake. So when you say pseudo-stratified columnar, what does that mean to you? I'll give you a second to think about it. Okay, false what? Not stacked, okay, because we're saying pseudo-stratified means what? Okay, it's not the columnar part that is fake, guys. It's what part that is fake? The number of layers that is fake, correct. So when you say pseudo-stratified, you're basically meaning the stratified part of it is what? It's fake. So it means how many layers would I have? If it's pseudo-stratified, if I use the word pseudo-stratified, how many layers do I actually have? 1, correct, you got it. So if you're looking, this is a really cool type of tissue, guys. So when you look at this tissue, it appears that it has what? Multiple layers of columnar cells stacked on top of each other, okay? Because you're saying a stratified columnar. Stratified means multiple layer, columnars means elongated cells. But when I use the word pseudo-stratified, it means it's what? It's a fake stratified. So in reality, if I look at the picture I have here, notice you only have 1 layer of cells, right? Now the reason it's called pseudo-stratified is because, see how the nucleus are on different levels? These are the purple dots are, yeah, it's illusionary, that's a good point. So because these nuclei are at the different levels, it makes it appear as they are stacked on top of each other. So I can say, oh, here is 1 layer down here, here is another layer, here is another layer. But in reality, it's just the cells are squished together so tightly that it seems that their nuclei are sitting on top of each other. Any questions about this? Awesome. So one of the main things that I want you guys to know for both your lecture and lab, which we will be doing today, and for your exams, is being able to identify main locations where you can find each of these cells. So here is an example of simple squamous epithelium. So this is found inside your lungs. So you can see the picture right here, that's your lungs. And basically what they have done is they've show you at a 400 total magnification. So if you see the lining right here where I'm running my cursor on, do you see there's little dark spots in them? What are those dark spots indicate, guys? Based on your knowledge, what do you think those dark spots are? Your nucleus, correct. Do you see them stacked on top of each other? Do you see them stacked on top of each other? The answer is no. So that means, what is this, guys? What type of tissue is this? A stratified or simple? It's simple, correct. And do you guys see any thickness to the cell, or are they relatively flat? They are flat, correct. So now we have determined just by looking at the picture is that you have a single layer of cells and they are flattened. Therefore, we can come up with the name simple squamous epithelium. Now you may see the same tissue, guys, in your kidneys. So that's, make a notation for yourself. If I ask you, where are the two most common locations where you can find simple squamous epithelium? Your two main functions, and they're listed here as well. Your kidney. You don't need to know what the glomerular and corpuscle are right now because we'll learn about them later. And then your lungs. Those are the two main locations. Now right here, what do we have is, look at the cells, guys. What is the shape of these cells? Anybody? What is the shape of these cells? Are they flattened, a square shape, or elongated cell? They're columnar, correct. So look, one single cell, look at where my borders are. Here's another single cell. Here's the third one. Now look at, oops, sorry guys. Look at the cells, guys, again. You have one beautiful nucleus in each of these cells. The cells are elongated, and there's a single layer of cells. Because there's a gap here, guys, you cannot say that they are stacked on top of each other. Basically, this is in your intestines. So there is a space, which means these two are not stacked on top of each other. If I'm looking at it, look at my hand, guys. If my fingers are representing the double layer, the top two fingers are forming the top layer and the bottom two fingers forming the bottom layer. And the space that I have here between my fingers is going to be this space right here. So because these are like this, I cannot say they are stratified because they're literally not stacked on top of each other. Now, last one that we have, oh, sorry, the location for this, as you can see highlighted, is your stomach and your intestines. So those are the most common places you can find them. A quick note in terms of magnification, guys. So the magnification you have in this picture is 1300-fold. What was your maximum magnification we did in our microscopes? Do you remember? 400, correct. So when you guys go to the tissues today to do the tissue lab, please, please don't expect this picture, because the magnification you guys are gonna see in your microscope is basically half of the size that are depicted here, or actually, I'm sorry, 1/3 of what is depicted here. So don't expect this beautiful, you know, easily identifiable columnar cells. They're a little bit harder to distinguish. Now here, each of these circles that you see are made up of simple cuboidal cells. If you kind of imagine lines separating this, again, kind of like a cursor, let me use my pen so I can show it to you. Okay, so if, oh, what happened? I'm on pen. Why is it not giving me a pen? Oh, technology. Okay, so if I'm looking at this, here is one cell. Okay, here is my second cell. Here is my third cell. They're just kind of bundling up together. Are they elongated? Or are they square shaped to you? They're square shaped, right? look at the difference, guys. They're more square, they're more cube shaped, correct. They're also not flattened. Now again, there is a cavity right at the center, so this structure is a single layer of cell, making this single as in simple, and because they're cube shaped or square shaped, they would be simple cuboidal. Now, where is the best location for this category? It's still found inside the kidneys. As you can kind of see, they're both, the simple cuboidal and simple columnar are both found in your kidneys. So kidney and kidney tubules, they're both found inside your kidney. Different sections of your kidney, but both in the kidneys. Here is an example of the pseudo-stratified, guys. Again, here is the layer that I'm looking at. Let me change my color. Sorry, guys, 1 second. So here is the epithelial layer I'm looking at from here to here. Again, the dark spots depicting what? What are these dark spots, guys? These are my nucleus, correct. See how it appears that they're stacked on top of each other, giving the illusion of multiple layers, but in reality, they are identified as pseudo-stratified epithelium. Anybody can tell me without looking at the label, what are these structures, these little hair things extending? They're cilia. What's the job of cilia, guys, typically? I mentioned this last time when we were talking about flagella, correct, help move. This is actually one of the things that are found in our lung tissue, guys, and I'll show you guys when we do respiratory system. So these little hairs kind of do this type of movement, like the algae at the bottom of the ocean. They do this kind of motion. And what they do is they actually, through their motion or movement, they move debris from your lung tissue, or before it gets to your lung tissue, it removes it from your respiratory path. So it doesn't allow those basically dust particles or harmful material to reach your lung. A lot of time through a smoking, by age, these cilia start to get destroyed, or by pollutant if you live in a pollutant environment. And that basically makes you more susceptible to those particles getting into your lung tissue, which is really sad. Any question before we move on, guys? Awesome. Okay, so what I don't know how this exactly relates to COVID, so I can't answer that, because honestly, I have read so many contradictory papers on this that I cannot answer that 100%. So we're just focusing on what I know 100%, not what is in the process of, I guess, being understood. Sorry. Okay, so multiple layers of cells or epithelial cells are called stratified. And again, we learn about them that we're going to be stratified squamous, cuboidal, and columnar. If I ask you guys, what is the main function of having a stratified epithelium? It's that their major function is going to be protection, and they always regenerate from below. And you'll see that in the integumentary system, as we'll talk about it after this PowerPoint. Something that I forgot to mention to you guys before is about the basal and apical surfaces. So let me just take a step back here. So notice how it says apical surface versus basal surface. Basal surface means at the bottom, at the base, which is kind of self-explanatory, which means apical surface would be the top surface. So the top surface versus the bottom surface. Same thing applies if you have multiple layer cells. Apical would be on the more superficial aspect of the tissue, and then basal layer would be at the base of it. So basal cells usually divide and then basically push the apical cells upward to replace the older ones. So again, if I go back to the picture here, so if I have cells, let's say this line of cells at the bottom, these ones that I have here, they're undergoing cell division. Everybody remember cell division last time? Cell divisions are basically taking one cell and making copies of this, right? So one cell becomes two cells. So the cells that are located in the basal layer or basal surface start to reproduce and basically push up. So these cells that are on the top will be the oldest layer of cells that you have. The basal would be the youngest, the newest cells that are formed through cell division. And then the apical cell would be, correct, they will be replenishing those. And the apical cells would be basically the cells that are either dead or dying and then gets removed as they come into the contact with the environment or the internal organs. We'll talk about the stratified cuboidal location in just a minute. Okay, we also have two things in terms of the type of the squamous cells or stratified squamous cells we have. They're called keratinized versus non-keratinized. Again, you'll see this word when we talk about integumentary system later on. But basically, their job is to waterproof. These are proteins. So keratin, or when you mention the word keratin, there are proteins that are found inside your cells, and they're essential for basically waterproofing the layers of your epithelium. You're only going to see this in the layer of the skin that is basically coming in contact with the outside. You cannot see keratinized cells inside your body, okay? What I have inside my body lack keratin, so they're called non-keratinized cells, which are basically esophagus, found in the vagina. Again, these are the ones that are internal, right? There is no dead layer of the cells that are packed with keratin for the purpose of waterproofing. Because if you're inside the body already, you're not gonna lose water from the inside. You're gonna lose the water from outside. So outside is keratinized, inside is non-keratinized. Is that logical to everybody? Any questions? Okay. Is the speed okay, guys? Am I going fast? Are you guys comfortable? Are you being overwhelmed? Good? Okay. Awesome. Okay, so look at this there, guys. Without looking at the labeling, guys, tell me what you noticed about these cells. What is the shape of these cells? What's the best way to describe these cells? Flat, cube shape, or columnar cells? Squamous, correct, which are flattened cells. And then again, you notice that there are many layers of cells. So this is gonna be identified as a stratified squamous, correct. So you have many layers of cells. Let's say this is about 20 layers of cells stacked on top of each other. And these are identified as stratified, and because they're flat, they're stratified squamous. The example you see right here is an example of the keratinized cells because they're showing you your skin basically. And these cells that you see on the top, this basically a very thick layer, correct? That's going to be dead keratinized cells, which are basically providing an extra layer of protection. So this layer that you're touching right now, what I'm touching, that's the layer of the skin that is directly in contact with outside, are basically dead cells. So when you wash your hand and that grime come off, or you do exfoliation, what are you getting rid of? Dead skin cells. This is as simple as I can get it. Exactly. Okay, so here's an example of the stratified cuboidal and an example of the stratified columnar cells. These two types of tissue, we don't even look at them in terms of histology in what is this? Your lab, because they're so rare in our body. But these are basically, if I ask you for a specific location for them, the location for stratified columnar in our body would be the salivary glands that are located either on the side of the face or underneath your tongue, or when we talk about stratified columnar cells, they're found in the urethra, which is basically the tube that exits the or excretes urine from the body. The main function for this is also protection. So there's a lot of protection associated because it opens up to the outside. How come some people have thick dead cells? They just do. I mean, the number of the layers, if you look at the number of the dead skin cells, they actually differ from one person to another. So that's just something that the body does. The other reason is you might not be getting rid of as many dead skins because you're not cleaning your skin as well. So the dead skin cells linger on the surface. But typically what we have is, the number differs from one textbook to another, between 20 to 30 layers of dead skin cells on top of each other. No, they don't. So on the skin, the cuboidal cells eventually don't become squamous. It's just that there's a lot more pressure on the superficial aspect of it. And then the cells that are on the bottom, there's not that much force on it. So they appear as more cube shape, but in reality, there's still going to be a squamous epithelium. No worry, Paula. Okay. Transitional epithelium is a really cool one, which is what I just mentioned in terms of them being cube-shaped versus squamous cells. Doesn't apply to the skin because the skin doesn't have that level of stretching. But think about the bladder, guys. So when bladder is empty, it basically collapses inside the pelvic cavity, and it's like a really tiny structure. Now, that structure, as it basically fills with urine, it can get basically ballooned out. So you have to have the ability to stretch the cells to make them basically expand and allow the urine to be carried inside the urinary bladder. So these type of cells, if you look at them, when the bladder is empty, they're more cube-shaped, okay? But then what happens as the bladder starts to fill? They're gonna transition to a squamous cell. So they're basically gonna get stretched. So if you have something that's cube shaped and then you stretch them, they become flattened. So take a look at this picture. So look at them when they are, basically the bladder is empty. They're pretty cube shaped. Yes, I know it's not a perfect cube. But when the bladder starts to get filled, then the cells are going to stretch out and appear more flattened. Where would you be able to see this type of cells? They line both the ureter, which is the tube you see right here, that transfers the urine to the bladder. And then you also can see part of the urethra as it goes out of the body. You also have those transitional epithelium. Any question about epithelium before we move on? Any question I missed that you asked and I forgot to answer? Okay. So this one's gonna blow your mind away, guys, because connective tissue is one of the coolest tissues, but it's also one of the more complex of the four. Stratified squamous, the best example would be your skin. You have them also lining the vagina. You have it line the inside of your mouth. Did I miss one? I think those are the three main ones that I want you guys to know. Inside of the mouth that I didn't mention actually, vagina, which is non-keratinized cells, and then your skin would be another example of it. Okay, so let's take a look at the connective tissue. Connective tissues are basically, as I mentioned, the main goal would be support. How do they exactly support the rest of your body? They allow you to connect your cells. They form your skeletal system. As I said, bone is a connective tissue. They store and carry your nutrients. this store part, if you want to make a note for yourself, we're talking about the fat tissue, which is also known as adipose tissue. So this is the fat tissue. And then carrying nutrients, that would be your blood. Your blood is carrying nutrients and your gases. They do surround your blood vessels and your nerves, so they basically provide a layer of protection for both your blood vessels and your nerves. And then physical protection and immunity. They are part of their blood in terms of protection, because you have white blood cells, and you also have sporadically cells that are located in tissues like areolar tissue that also act in terms of protection. And we'll take a look at them as we go through this. It becomes a little more clear. So let's take a look at the connective tissue. So connective tissue is the most abundant type of tissue we have, which kind of makes sense. They are fibrous because when you hear this word, guys, fibrous means there's a lot of protein fibers, lots and lots of protein fibers. We'll take a look at them again in just a few minutes. They could be supportive. If they have a role in supportive, they can be part of basically your cartilage or bone. Again, hence connective tissue is the most abundant one. And then the main category, if they are fluid, it would be your blood that basically circulates oxygen and carbon dioxide as well as your nutrients. Now, when you look at the epithelial tissue, all the 7 types that we took a look, they all got stuck together, right? They were either stacked on top of each other, but they were very close with each other. There was no gap between these cells. But when we look at connective tissue, for most part, these connective tissue, you have, yes, one cell here, one cell there, one cell there, one cell on their time. So there is no basically direct connection between these cells. Now, the space that is basically the background, where these cells are located sporadically through it, is referred to as what? Extracellular matrix. That background where your cells are going to be located, they're called extracellular matrix. These extracellular matrix contain material called extracellular material. So kind of makes sense. I need to keep an eye on the time. Okay, this is your, I guess, go-to-go chart when it comes to connective tissue, guys. This is a really important chart. We're gonna walk through it and then basically look at each of the tissues in more detail. Connective tissue has 3 main breakdowns: what we identify as proper, what we identify as fluid, and what we identify as supporting or supportive. If it's proper, it can have lots and lots of protein fibers or very little to no protein fibers. So if I have very little to no protein fibers, I call them what? Loose connective tissue. And if they have lots and lots of protein fibers, they call dense connective tissue. If we're using the word fluid, fluid basically means a lot of water, right? The main type we have is your blood, as we mentioned multiple times already. I don't discuss lymph with you guys, so you guys can basically ignore that. And in terms of support, basically providing support for the rest of the body, you will have your cartilage and your bone. Now, bone, it's basically bone. There's no breakdown or further breakdown to it. But for cartilage, you actually have 3 main categories. They are hyaline cartilage, elastic cartilage, and fibrocartilage. And again, we'll take a look at how we distinguish them and where you can find them in your body. Blood is blood. Again, there's no breakdown to it. For dense, which is again, the main one is that you have lots and lots of protein fibers. Dense, you could have dense to regular, which basically means if I'm looking at the protein fibers, they are parallel to each other. So these lines are just going across, oh, sorry, parallel to one another. There's no crossing. But if I look at the irregular version, what would I have? Fibers going this way, fibers going this way. So they're crisscrossing or they're going over each other. So basically irregular pattern. For loose connective tissue, what do we have? Again, very limited or no protein fibers. You have one called areolar, one called adipose, and one called reticular. Now, I'm trying to keep this as simple as possible. There's a lot more information that we can get into that helps basically with people that are interested in pathology, but we're gonna try to keep it as simple as possible. So let's do this. Okay, so what are the protein fibers that we're describing? So again, protein fibers are what makes something either loose connective tissue or dense connective tissue, or even supportive connective tissue. You can have what we identify as collagenous fiber. These are typically found in your tendons, ligaments, and dermis of your skin. You have fibers called reticular fibers, which are thinner than collagen, and they're not as strong. They don't provide as much strength for the tissue. And then elastic. Elastic is kind of self-explanatory. Basically, these fibers, if you stretch them, it's not their ability to stretch, it's their ability that if I let go of them, what are they gonna do? Recoil back to their original. So I tell my students, for you to understand elastic, is there's a lot of elastic fiber in your skin, right? So when you're young, what is the quality of your skin that people are very proud of and try to keep it as long as they can possibly be? That the skin is stretched beautifully, right? It's smooth, correct. It doesn't sag, right? So as you age, what happens is the elasticity of these protein fibers in your skin goes away, okay? So what happened? I can still stretch my skin if you're old, right? But what happens? When I let go, it just sits there, right? It just sags there. So that's why the word elasticity is so important. It's not the ability to stretch, it's the ability to see and make sure the tissue is recoiled back to its original shape. Yeah, you can do plastic surgery, but that doesn't necessarily fix the damage. It just covers the symptoms, I guess. Anyway, sorry. Okay, so what are the type of connective tissue? We already went over this, so I'm not gonna repeat myself. We're just gonna do the fibrous connective tissue to start with. So fibrous connective tissue, the loose version of the fibrous connective tissue include areolar connective tissue. The main job for it is basically supporting and binding tissues, holding body fluids, defending against any type of infection because they do have white blood cells. They have a storage of fat, so they have some adipose cells inside of them, and they help remove the waste product. So if there's waste products circulating in the body, they can actually end up in the areolar tissue. Now, by looking at this picture, the most important thing I want you guys to take a look at is not identifying the cells or the specific protein fibers. What I want you guys to understand is this, and this only. The little lines, either thick, like this one, or really super thin. All of those are going to be protein fibers. I don't need you to tell me what protein fiber, guys. As far as I know, there are protein fibers. Don't distinguish that. That's not the goal of this class. And then the second thing is these structures that you see, these darker spots throughout the tissue. These are going to be my cells, okay? Do you need to identify what type of cell? And the answer is no. As far as you know they are cells, then you're okay. That's it. That's all you need to know. Okay, so moving on. I forgot to mention the location for this. Where can you find this? It's underneath your skin. So areolar connective tissue is underneath your skin, and it basically helps you bind your skin to the muscles underneath it. So it's a connection basically, again, right? Kind of like a glue. It holds the, again, the skin to your muscle underneath. I'm gonna kind of discuss you, but that's the easiest way for me to describe it. Have you guys ever skinned, I don't know, chicken is the easiest way. Even if you know, a store-bought chicken, you know, sometimes when you separate the skin, there are those little tiny fibers, kind of look like spider webs. Anybody has seen those? So those are basically your areolar connective tissue. What are they connecting? The skin to the muscles that are underneath it. So it's basically all over, but if I ask you, what do you categorize this as? You categorize that as areolar connective tissue. Okay. Next one is adipose tissue. What do you need to know for adipose is, first of all, the type of cells that are found in the adipose tissue are called adipocyte. Again, the word adipose means fat, cyte means cell. So adipocyte basically means fat cells. Now, please, if I in the exam ask you guys, what are the cells of the adipose tissue? Please do not write fat cells. We are an anatomy class, which means I need you guys to actually write the proper terminology, which is adipocyte. What is the main function of the adipose tissue? Is to store nutrients. Because if you guys remember, what did I say about the most important function of fat? Anybody remember that? What's the most important function of fat from last lecture? Store energy, but what is the key word before store energy? It is a storage of energy, not just energy, guys. Starts with an L. Nobody remembers that? I spent quite an amount of time on this. When we were comparing carbohydrates versus lipids, what is the main difference between those? I could store both of those as energy, right? But what is the difference? What's the difference between carbs and lipids in terms of energy storage? Long-term, thank you, Ashley. So when you think about your adipose tissue, their long-term energy storage versus carbohydrates are short-term energy storage. This is a typical exam question, guys. Make sure you understand this. Carbs are short-term and fats are long-term energy storage. So where can I find my adipose tissue? Most commonly found underneath your skin on a layer called hypodermis. Hypo means below, dermis. Dermis is the layer of a skin. You know how a lot of times when you guys get an injection in your arms, that injection basically is directed into the hypodermis, or the fat layer underneath your skin. So you don't actually get it directly in the skin. You can also find adipose tissue around the heart, in the lymph nodes, your eye, and some muscles. And yes, if you're like me and you have a belly fat, you also can find it in your belly fat. But typically, if you're talking about a normal adult healthy, you shouldn't have a significant amount of fat storage in your abdominal area. Not the case for me. Okay. Loose connective tissue, the last category we have is reticular connective tissue. Examples of that is found in your spleen. Thank you, Alpha. I did not know that. So it's found inside your spleen, lymph node, thymus, and bone marrow. Can you guys tell me what I've listed here? Which organ system do they belong to? So spleen, lymph node, thymus, and bone marrow. What are they belong to? What organ system do they belong to? Any idea? Not endocrine. Look at the words that I have, guys. The actual name of the system is there. Correct. Lymphatic system. Spleen, lymph node, thymus, and bone marrow are all part of the lymphatic system. Correct, guys. The way I identify this tissue when you're looking at it is that they kind of, if you imagine you have a branch of grapes, right? So here is the branches of the grapes, and these are your little tiny grapes. Okay, so this is one of the easiest type of tissue to identify because it's very particular in its characteristics. So if you kind of see this kind of very thick branching going through it with the little tiny circles all around it, that would be identified as your reticular connective tissue, which is mostly found in your lymphatic organs. Can I answer any question for you guys so far? So those are your three loose connective tissues. Again, fat or adipose tissue, your reticular, and the areolar connective tissue. Good. So let's talk about your dense connective tissue. I kind of gave you an idea of what that means when we're talking about dense regular versus irregular. Now you can see the pattern. So I kind of like to see this is versus when you have a perfect ocean with beautiful waves. Look at this, see how beautiful the pattern is? All fibers are parallel to each other. Versus when you have a storm and you have basically water churning everywhere, right? There is no particular pattern to it, right? The protein fibers are just going everywhere. So that's the easiest way for you to identify between dense regular versus irregular connective tissue. So when you're looking at your location for irregular connective tissue, the best location would be the dermis of the skin. So if you're looking at your skin, and you'll see that on the next PowerPoint, the top layer, what I'm touching right now, that is referred to as the epidermis because it's on top of the dermis. Epi means above, right? Dermis means the skin layer. So that layer, which we talked about earlier, is made up of keratinized, stratified squamous epithelium, many layers of flattened cells. Right underneath this, you have this really thick layer, which is your dermis layer, and that layer is made up of dense irregular connective tissue. It's about 80-20. 20% is the stratified squamous, and the other 80% would be your dermis layer, which is the dense irregular connective tissue. Dense regular connective tissue, best examples would be ligaments and your tendons. Can you guys tell me what are ligaments exactly? Because a lot of people just use those words interchangeably versus, the proper terminology. So what is ligament? Actually, attaches to muscles. What does that mean, first of all? What is attaches to muscles? So, but let me backtrack for you guys. When you talk about ligaments and tendons, they connect one to another. So which one is bone to bone? Ligaments or tendons? Let me ask you this way. Okay, so I got both ligaments and tendons. So ligaments are bone to bone. So if you're connecting one bone to another, that's a ligament. Therefore, when you connect your muscle to your bone, that would be a tendon, okay? So please, when you guys, as a scientist, moving forward as an anatomist, you guys make sure you guys can distinguish between ligaments, bone to bone, versus tendons, bone to muscle. So let's move on to the fluid portion of your connective tissue, which is your blood. Again, guys, one of the first things that you guys want to notice is when you're looking at the sample of the blood, look at the magnification I have depicted for you here. It's 1500, guys. This is almost 4 times the capacity of your microscopes, your typical light microscope. So of course, you're not going to see these beautiful large cells that are easily distinguishable. But for our purpose, I want to kind of show you this really zoom in version. So what you have is you have quite a few of these pink circles, and these will be identified as your red blood cells. Another name for red blood cells are erythrocytes. Erythro means red, cyte means cells. So basically you're saying red cells. When you see these relatively larger cells with a very pronounced nucleus inside of them, those would be your white blood cells, also known as leukocytes. And notice right here, they're using the word like neutrophils or lymphocytes. These are categories of white blood cell we'll discuss later. So don't get confused. These are still going to be your white, sorry, my thing is not working again, white blood cell. And then they're not labeled here in this picture, but you guys see this that kind of looks like a dirt in the background. These are actually platelets. They are essential for blood clotting. So whenever you basically cut yourself, how fast you stop bleeding or forming that clot depends on the number of these platelets that are circulating in your bloodstream. So when you do a CBC, or basically a full blood count, they also look at your platelets for the ability to effectively blood clot if you're doing a surgery, for instance. And if I ask you what is the main function of the erythrocyte, it's transporting oxygen. And also, I'm going to note for you guys your CO2, which is your waste gas. Leukocytes are responsible for production of immunity, and platelets we already talked about. Cartilage. Cartilage is one of the cool tissues that we have, guys. Cartilage is very flexible, and it's relatively firm, even though it is flexible. The main reason for having that capacity is because it holds a lot of water, which gives it that flexibility. But it also does contain a lot of protein fibers, which gives it that firmness. So it's a combination of basically water and protein fibers. Really, really important characteristic of the cartilage, guys. No blood vessels or nerves are found in your cartilage. So basically, if you cut a cartilage, it won't bleed. And then you also probably won't feel any pain unless you cut deep enough to go to the tissues underneath it. So, you know, when people pierce their ear portion, it's not as painful because that's mostly cartilage tissue. And therefore, it's not as painful. Some people might disagree though. It's like, oh no, it was extremely painful. Okay. So what are the cells that are found inside the cartilage? These words should sound familiar to you guys. Chondro, we learned that it means cartilage. Cyte means cell. So regardless of what cartilage tissue we're talking about, they're still gonna be called chondrocytes. And here's are the three types. The three types are hyaline, elastic, and fibrocartilage. Yes, you can regenerate them. There is nothing wrong with your ability to regenerate. They just don't have blood vessels and nerves. And the main reason, so think about it, when you twist your ankle, you're typically damaging ligaments and tendons. And it takes a very long time for that to heal. But it still heals, but it just takes a very long time. The main reason is because there is no significant blood vessels going to the tissue to help regenerate the tissue and speed up the healing process. But yes, you would be able to produce the cells. And I don't know if your physiology instructor will go into more detail of how these cells actually regenerate through the process of cell division. There are two main mechanisms they do that. Okay. Hyaline cartilage. What's the best way to identify hyaline cartilage? If you take a look at this, do you see there is nothing in the background and then you see these kind of white dots in them? But the background is pretty clean. There's nothing like, if you look at this kind of white section, I said white, this is clearly white color. This blue color right here, there's nothing inside of it, right? There is no protein fiber visible. So when we do a staining, when we do coloring of the hyaline cartilage, so we can visualize it, the collagen fibers are not going to be stained. So what you end up with is this beautiful glossy background with your chondrocytes throughout your cells. And again, chondrocytes are your cells. So the white spots you're seeing, those are your chondrocytes. And then basically the background would be very clean. Now, please do note the locations. Hyaline cartilage is relatively common in our body. They're found inside our joints as a way for us to lubricate when the two bones are rubbing against each other. They're found in my trachea, which is the air pipe that goes down my throat. It helps keep it open. This part of your nose that is flexible, that's also made up of hyaline cartilage. And really, really cool thing, the first 8 weeks when the embryo and fetus is being developed, they have what we call a fetal skeleton. It's not a bony skeleton. It's basically made up of hyaline cartilage. So what you see in red is basically hyaline cartilage, which resembles bone, and it eventually gets converted to bone. And we'll talk about that in the skeletal system lecture. But it's pretty cool. You actually start with the cartilage and then convert that to bone. Elastic cartilage, guys, look at this. So you're still gonna have your chondrocytes, right? Similar to what we described. But look at the background, guys. What do you notice? A lot of background, right? It's like somebody took a pen and just went through and colored the background. So that is actually your elastic fibers that are being stained. And that's the easiest way to distinguish what is elastic cartilage versus the clean, glossy background of the hyaline cartilage. Where can I find it? Easy way to remember, E for these two. E for elastic, E for ear, E for elastic, E for epiglottis. If you don't know what epiglottis is, we'll go in more detail in terms of respiratory system later. But there's a little flap right about here in your neck where your air passageway is. It just basically closes when you are eating. So make sure there's no food going down your air passageway. And when I'm breathing air in and out of my lungs, it basically opens up so the air can go down your respiratory system. So it's a gateway if you want to think about it. And then fibrocartilage, which is the third category. Whenever we stain them, you get this really, really beautiful blue color background with purple streaks through it. Again, the spots that you see throughout this, these will be your chondrocytes. And these fibrocartilage, guys, this is one of the coolest characteristics they have. They have the ability to absorb a lot of shock. Okay, so when you basically put a lot of pressure on them, the pressure stays in them and doesn't get transferred. So it's really cool. So where can I find this? Best place is the intervertebral disc. Break down the word for yourself, guys. Inter means what? Not inside. Inter means between, correct. So intervertebral means it's between your vertebra. So take a look at this picture. Here is my vertebra in white, right? And the red lines that you see going through them, separating them, would be the disc of fibrocartilage. So you know how people say, oh, I have a disc problem. It has a lot of pain. They have a lot of back pain most of the time. Sometimes it radiates down their legs. So that disc problem is basically a problem with the fibrocartilage, either being out of alignment or it's been worn out because of many usage, or you might have osteoarthritis or rheumatoid arthritis. All of these contribute to damaging this intervertebral disc and as a result causing severe pain in that individual. Another place that you can find fibrocartilage is an area called pubic symphysis. So where is pubic symphysis? If you take your two pelvic bones, the two pelvic bones come together in the front, right in the middle. So in the pelvic cavity, there's two pelvic bones, they come together. The area where these two pelvic bones literally come together is called the pubic symphysis. So it's literally, guys, holding you together. This pubic symphysis, this fibrocartilage is holding you together in the front. So kind of a cool fact. So if this is my pubic and then where my fingers are touching, that would be my pubic symphysis. So here is the opening of basically the birth canal if you're a woman, okay? So if the birth canal is small, then the child cannot pass through, right? So if you not suffer, that's a really bad word, I apologize. If you've been pregnant, if you've been blessed to be pregnant, one of the things that may happen to you is you may feel like pain in the pelvic region. And the reason for that is this cartilage, this pubic symphysis, starting to kind of loosen up a little bit to open up your birth canal to allow the shoulders of the baby to pass through. And in many cases, actually, I know people that after giving birth or as a result of their pregnancy, they don't walk properly anymore because that pubic symphysis basically shifts their pelvic region, making it more difficult for the legs to be aligned. So they actually need treatment to be able to kind of repair the damage. But that was interesting to me as a woman undergoing childbirth. It's kind of cool to know that, you know, you actually can adjust, not significantly, but minor adjustment into the size of the birth canal. It's not scary, it's cool. The size of the birth canal to basically ensure that the baby can pass through this properly. It's the blessing of a woman giving birth. It's not scary. Women are amazing. I know, I'm one of them. Clearly, I'm not a modest person, guys. Okay, moving on. We're actually going to take a look at, when we do a skeletal system, we'll take a look at the differences between the pelvic bone in the male and female and how they differ in shape that allows women to basically become more, I guess, prepared for childbirth. Okay, so we're going to talk about bones, guys, and then we'll take a break and come back and continue after that. So for bones, you guys do need to know that there are, first of all, 3 main categories of cells, or bone cells, I should say, present inside the bone. They're called osteoblast, osteoclast, and osteocyte. Everybody remember the word osteo means what? It's kind of self-explanatory, but just in case. It's just means bone, correct? Anybody knows what the word blast imply? It doesn't mean blasting something apart, guys. That's not what it means. So don't write that. It's not an explosion. It's not an explosion. So blast means immature. In Latin, blast implies immature cells. So basically, baby bone cells are called osteoblast, and they're essential for bone building. So osteoblasts are immature bone cells, essential for building bones. Opposite of the osteoblast, when these are building bones, what is osteoclasts are going to do? Destruction of the bone. And these are really important, guys, for helping you balance your calcium level in your bloodstream. Have you heard of the condition called, medical condition called osteoporosis? It's really common in elderly. So the main reason why somebody will develop osteoblasts and osteoclasts is significant shift in the number of the osteoblasts, osteoclasts. So bone building ability and bone destruction ability goes out of whack, basically. And that causes the cases of osteoporosis. Now, if you have a mature bone cells, which is basically their job is to just sit there and make sure everything is running as smoothly, maintaining your bone, these are called osteocytes. So 3 types: osteoblasts, osteoclasts, and osteocytes. when you look at a bone tissue, guys, when you look at it under the microscope, you can't see these two. You're only gonna see the osteocytes because the bone is already formed and it's happy, and all you're doing is maintaining it. Okay, so, oh, I'm sorry. I'm gonna add a couple things because I thought I had them, but I don't. This structure, do you see these beautiful circles right here? You have many of them put together. These are structures or units called, make a note for yourselves, please. They're called osteons. Yeah. Sorry, I'm literally typing with my keyboard because the other ones doesn't work. So these are called osteons. Basically, whenever you look at a bone, you will see these patterns of circles inside of them called osteons. And then you see the darker spots throughout them. So these cells that I'm kind of marking right there, the dark spots, these are your osteocytes. Sorry, my neighbor is turning on their car if you're hearing that. The osteocytes are inside these cavities called lacuna. So what is a lacuna? Lacuna is basically a cavity that is holding my cell. These are words that you guys need to know for your exam, for your lab exam. And then I think those are the only ones I want you guys to know. Circular units are called osteons. Darker spots through it would be osteocytes, which are sitting in these little tiny cavities called lacuna. Development of what? Sorry, Alpha, I don't know what that means. Okay.
Well, what I was saying, if I can unmute myself.
If I can do what?
I say, can I speak?
Yes, you are speaking.
Okay. What I was asking is that in terms of this bone deficiency and bone building apparatus in our body, how does one's race affect those abilities as you get older?
I don't know if there is a significant study on how race is affected by us, how race, I guess, affects the rate of osteoblasts and osteoclasts. What I can tell you is there is a lot of research on what I know is differences between male and female in terms of osteoblasts, osteoclasts as a person ages. Women get more affected by osteoporosis because they have fluctuation in their hormone level after menopause. Is there a significant difference in terms of race? I cannot answer that. Okay, guys, let's go ahead and take our break. So it is 9:20, so be back by 9:35 for our break. Don't sign out, guys. Just keep your phone on or your computer on mute, step away, do whatever you need to do, and then we'll continue at 9:35, okay? Pause my recording. And then, can you hear me now, or you still can't hear me? Okay. I wanted you guys to see me a lot more. Sorry, I apologize. I can, regardless of what part of the house I go to, you can still hear it. So I just decided to stick to my original plan. Hopefully they'll be done in about an hour. I'm just kidding. They're pretty fast, so we'll see. Okay, so let's go ahead and move on to our muscle tissue. Muscle tissue, we have 3 different types of muscles. Oh, I apologize. Somebody asked me, Wendy, I think, was asking me about the difference between osteopenia and osteoporosis. I didn't see your question, I apologize. Osteopenia is, it's a stage before you actually be diagnosed with osteoporosis. That's the easiest way for me to say it. So you do have loss of bone mass because there is an imbalance between your osteoblast and your osteoclast. However, the loss is not significant yet by the measurements that your doctor has set for you to be diagnosed with osteoporosis. So if you pass that kind of the threshold, that a specific threshold that the doctor has set, and then you have osteoporosis. But if you're below that, but you still have loss of bone density or loss of bone mass, then you will be diagnosed with osteopenia. And the other difference is that when you're on osteopenia, you have osteopenia, they don't actually give you medication, but if you have osteoporosis, they actually subscribe either a weekly or a monthly medication for you. It's repairing, it's just basically making sure that the bones doesn't fall apart. That's the easiest way of, so when you say bone maintenance, it's basically, it keeps the environment happy. Sometimes when I talk about this, the way I look at it in terms of bone maintenance for osteocyte is you want to build something, right? Let's say I build a building, right? That's your osteoblast, right? Now, when the building is ready, right, everything is still running, right? But you need that maintenance crew to make sure everything is good, right? It doesn't necessarily do anything major. It's just kind of, yeah, repairing might be a good word of saying it. But in a long term, your osteoclast and osteoblasts are the ones that are actually going to fix if there is any damage to your bone. Osteocyte does not really have that power. And we'll talk about that briefly when we talk about a skeletal system later on as well for Unit 2. I think I got all of you guys' questions. So if something I missed, please let me know or retype the question for me and I can answer that. Okay, so when we talk about muscles, there are 3 categories of muscles: a smooth muscle, cardiac, and a skeletal muscle. When we're looking at these muscles, the way we're going to identify or characterize them is a few features. One is where they can be found in our body. Second is their movement voluntary or involuntary? Third is, what is the number of nucleus they have per cell? So typically we say, oh, it's only 1 nucleus per cell. That's what we typically see. But again, there are cells that do have multiple nuclei per cell. Next one is what we identify as striations. Striations is basically these lines that you see going through your muscle. It's a light and dark pattern. So basically think about stripes on a zebra. That's what you want to think about. Light, dark, light, dark. That's called striations. And again, it's a feature that we can help us distinguish different categories of muscles. And the last one we have is what we call intercalated disc. This is basically a desmosomes, if you guys remember from our last lecture, where it allows the cells to be connected and allow the tension to be spread out. So if a cell has it or doesn't have it, I guess I should say, then that's a feature or distinguishing characteristics. So let's go ahead and compare these together. So a smooth muscle. Here's a picture of a smooth muscle. Again, you can see the nucleus very clearly in these cells. If we were only talking about a single cell, so if I pull a single cell out of this tissue, the cell is a spindle shape, which basically means you have kind of a thin middle section where your nucleus is. And then as you go to either end, the cell starts to narrow down. So that's a spindle shape, thick at the center, thin on the ends. There are single nucleus, as you can see in the picture here. There is no striation, so there is no dark and light pattern going through your muscle. And I'll show you what that looks like if it is present in the cell. There is no intercalated disc. There is no connection between the cells to limit the tension, because these don't really have a lot of tension on them. It's not like cardiac muscle that's continuously beating, right? A smooth muscle typically found in your intestines, your stomach, your bladder, your uterus, the color portion of your eye, which is the iris of your eye. So again, they are not significantly under force or pressure, so they really don't need that intercalated disc. And involuntary movement, you guys are gonna laugh at me, but the way I think about this is when I think about the movement of muscles. If these muscles move really rapidly, they give you diarrhea, especially if you're talking about digestive system, right? If these muscles move very slowly, then you get constipation. So to think about them, if their action is voluntary or involuntary, is thinking as, oh, I can control when I will have diarrhea or when I would be constipated. I can control that, therefore the muscles are involuntary. And hopefully this will stick to your minds and will never leave you, even as Wrench says. You can explain that to your patients. Now, when we're looking at cardiac muscles, so what does the word cardiac imply? It basically means your cardiac heart, correct. So it can only be found in heart, kind of logical. Its characteristic is striations. So let me show you what the striation pattern looks like in this picture. So let me get my pen. So here is one cell. So let me show you. This is one cell and the pattern is like this. First of all, if you look at the shape of this, these cells are identified in terms of shape. They are branched. So you can see kind of like branching of the tree. Oh, I can't spell. They are branched. That's the way we categorize their shape. Wow, beautiful typing. Okay, so what you see, if this is my cell going this way, going horizontally, you see this light and dark pattern going this way? These are my striations. So that's the striation pattern visible in our cardiac muscles. They also have intercalated discs, which are, again, the point of tension or releasing tension. These darker lines that you see, not light as the striations, but they're very visible lines. Those are called your intercalated discs. There are usually one nucleus per cell, so you will see one darkest spot in each of the cells. Sometimes, because the cells are too long, then you might have multinucleated cells. But the best way to say them, usually one nucleus. Logically, the movement of these muscles are going to be involuntary, right? Because again, I can't tell my heart to slow down or to speed up just because I said so. Somebody asked me, well, what about when I do, these relaxation exercises that helps me, control my heart rate? Okay, that is different from me telling my heart, beat 150 beats per minute, beat 50 beats per minute. I can't do that, right? I can't tell your heart. I can do things that allows me to slowly adjust my heart rate, but you cannot really tell your heart to do something unless your body tells it to do so, or your brain tells it to do so. So it's not a voluntary movement. And then the third category we have is the skeletal muscle. So these cells are pretty long, guys. So it can be as long as a single inch up to about 10 inches long. So that's a very long structure for a single cell. So if you have a cell that is this long, guys, you need more than one nucleus to support and control the activity of these cells. So all of the cells in your skeletal muscles are going to be multinucleated, as in they have multiple nuclei. These muscles are under your control. I can decide when to do this. I can decide when to bend or flex my muscles. So the movement is voluntary, with the exception of reflexes when your hand just jerks or your foot just jerks. There are striations. So again, if I take this, here's my muscle. There's a single muscle. The dark purple spots are my nucleus, and then the pattern you see going this way are my striations. And then where can I find this type of muscles? They basically attach to my bones, hence the name skeletal, as in they're connected to your skeletal system. So that's about it for the skeletal system, or I should say skeletal muscular tissue, unless there is any question about this. Okay, give me a minute. Okay, I know it is a lot of information, and we're not even done. But remember, you can always go back to the lectures and watch the videos on your own time and review them. And the good thing about today's lab is what I'm covering in lab for you right now would be repeated during, so what I'm covering in your lecture will be also covered in your lab again. So you get that second exposure, and hopefully that will help you recognize the information a little bit better. Okay. Last one we have within our tissue is the nervous tissue. So nervous tissue is found in your brain, your spinal cord, and your nerves, which is basically your nervous system. The main category of cells that we have are referred to as neurons, or you can simply call them nerve cells. Their main job is to really create electrical impulses. You learn about this in so much detail in physiology that's just mind-boggling in terms of the complicated pathway they take. But just for now, you do need to know that they create electrical impulses to basically control your body. If you look at a neuron, they have three major parts. This kind of a chubby center, which is where your nucleus and all of your organelles are. It's called soma or cell body. So make a notation for yourself, soma, or I'm just gonna type in the thing, cell body. So cell body is basically same thing as soma, where your nucleus and organelles are. You have these little tiny extensions coming off of them. These are called dendrites. And if you have one single long one coming off of it, that's your axon. So these are parts of the neuron. And then these little tiny dots that you see around them, you can see them in the picture. So all of these little dots you see in the background, these are called supporting cells, that their job is to basically help your neuron do what it needs to do. And they're also referred to as neuroglia, or glial cells, as it says here. So these are glial cells as well. So that's about it in terms of your tissue lecture. Can I answer any questions about the four major categories of tissue we talked about? Anything that just didn't click for you and you want to go over it? Don't be shy, guys. Ask your questions. I'd rather you guys ask it now than, you know, give me some really scary answer in the exam. No question? During exam, will the question based on this lab have images? Yes. So both for your lecture and lab, you should be able to identify the images and the components that are listed. So you'll see as you go through the lab later on today, that is still very similar to what we discussed here. It's just now you guys are going to do it by yourself rather than, you know, me telling you. But yes, you are required to be able to identify tissues by just looking at them. But that's going to be more for your lab. For your lecture, I'm going to more be focusing on the written portion. It's not like I won't have questions like that, but it would be more focused on the, okay, where can you find nervous tissue, or where is the common location for simple squamous, or which one of these is not a location for a stratified squamous. Questions like that would be more toward your lecture, and then identification would be more for your lab. Okay, just a quick note before kind of shifting our gears to our integumentary system. I haven't really had anybody visiting me during the office hours, and that's okay with me because I get a chance to grade your papers. But I do recommend for you guys, especially next week, to come to the office hours if you guys want to review a specific concepts, and we can have that kind of a more of a conversation rather than me just talking. So if you guys do have question about certain concept after you finish your study, you have that single hour before, right before your exam, where you can ask questions about the specific concepts. I know a lot of this is just so much information coming in right now that you guys get overwhelmed, and it's understanding, but again, that's part of the class right now. So please, please, I do want to see you guys during office hours. Log in. We can have a group conversation if you guys have questions, or you may not know that you have a question, but just being there and reviewing the concept may help you. I will be posting a study guide for your exam, so that's another way for you guys to know what concepts you need to focus on. And then the other thing I wanted to tell you, and just kind of remember, your exam is at the first half of your class during our next meeting. But I do recommend for you guys, actually I'm going to force you guys all to do that, to log into the Zoom and be on Zoom while you're taking your exam. And the reason for that is that if you guys do have questions, then I can answer those questions directly while you guys are taking the exam. And you can privately message me on the chat box, so you don't have to announce it to the whole class what your question is. But that's an easy way for you guys to stay in contact with me while you're taking the exam, to get you more of that, you know, face-to-face feeling that you can raise your hand and ask me a question. Is this making sense to everybody so far? Any questions that you may have? The question can be associated with the exam too. I just want to use this as a kind of a transition point between the two lectures. So also a quick mind break. It's next 19, then 26 will be your exam. Yes, next Saturday. Next Saturday from 8 to 9:30, I believe. I haven't set up the time, but it would probably be an hour and a half. And it's basically covering everything we have discussed from the first day of the class till the end of the class today. And I will show in your study guide as well if you want to see what concept is covered. Anything else? Any other concerns? I do take attendance at the beginning of the class. You don't need to continue typing your attendance basically. So if you wrote your name at the beginning, then you're good. You don't need to do it. Because if the numbers doesn't fluctuate, you guys are at 27 right now. So if that number changes, then I go back and see who dropped, or I ask you guys to do another attendance. But if the number remain at 28, I'm assuming everybody's still here. Don't know if you're behind your computers or not, but you're still logged in. Okay, don't know how many questions. I haven't written your exam yet. This is the first time I'm doing this exam online, so I haven't done that yet. The study guide will be up as soon as I get a chance to do so. Probably when you guys are working on your lab, I will upload that as well. Okay? Yeah, okay. I'm gonna make it 95 questions, so you guys just, you know, give up. No, I'm just kidding. No. But please, guys, one last recommendation that I want you guys to do, and it does help and it resolves a lot of the issues. First of all, do not take this exam on your phone. A lot of times things do not open up properly on the Canvas if you're opening it on your phone or on an iPad. So if you can, please use an actual laptop, and make sure that you have the Chrome web browser that is updated. So the most up-to-date Chrome browser is the best browser to use for the exam. I've never had any issues when students used it. The first time people using Internet Explorer, Safari, Firefox, these are going to give you trouble, and you really, when you have a trouble in an online setting, guys, it's going to make you stressed out, and it's going to make you not do so well. I have this experience from my previous students. So before you get started, sometime before Saturday at 8 o'clock, make sure you guys have, if you don't have it, download your Chrome web browser and make sure it is up to date. If it's not, it helps you a lot in terms of loading of the exam and making sure the pictures are presented properly in your exam. Okay. So I don't see any other questions. So I'm going to go ahead and get started with our integumentary system, which is our next lecture. Oh, and then one last thing before, completely unrelated to this, but I have made the decision not to go from this Zoom meeting to another one for your lab because I already set up your breakout session when you guys are logging in. So I just put you guys into your correct breakout room sessions. So when we're done with the lecture, don't log off, don't do anything. Just come back after our break, after our lecture break for the lab to the same Zoom meeting. So literally, like, assume you're taking a break between your lecture and lab. That's all you need to do. Don't switch between the Zooms, even though there is a separate link for your lab, we will not be using that. And if that didn't make sense, send me a chat message and then I'll make sure I explain it again. Awesome. Okay, so let's go ahead and start with our first system in our body, and this is our integumentary system, which is basically our skin, hair, nails, oil glands, sweat glands. Did I miss anything? I think that's it. So these are basically play multiple roles in our body. One of the main ones is protection. They're basically a way for us to separate the external environment from the internal environment. It helps you regulate body temperature. So I tell my students, think about when you are hot, what happens to your skin surface? It gets hot, and in many scenarios, it actually looks flush. You also sweat, correct? So all of these that you see, all of these changes that you see are associated with your body getting rid of extra heat. So flushing brings a lot of blood to your surface, your skin surface, and literally allow the heat to radiate out of your face, which is pretty darn cool. Of course, you do sweating. The more you sweat, the cooler your body gets. The opposite of that, so let's say you're in a really cold environment and you need to lower your body, you need to maintain your body temperature at 37 degrees. So the way you do that is the blood vessels that are on the surface of your skin literally shrivel up, or they get really small. So it limits how much blood comes to the surface, and it basically limits how much heat is going to radiate out of your face. So if you're in a cold environment and you touch your skin is also super cold. It's not because you've lost all of the heat in your body. It's your body's trying to maintain your core body temperature, so it let go of the heat that is on the surface and shrink up constrict your blood vessels so not as much heat gets lost through your skin. Cutaneous sensation, as we will see throughout the pictures, you have a lot of nerve endings that are built into your dermis, and these are basically the nerve ending that helps you sense change in temperature, change in pressure, vibrations, the feeling of different surfaces, like if the surface is smooth versus rough. All of these are your cutaneous sensations done by your nerve endings. And then lastly, excretion of waste. Your sweat actually releases a lot of unwanted material to the surface of your skin as well. So that's where the excretion of the waste comes from. So we already mentioned this. So we have, as part of the integumentary system, we have a skin, hair, nails, sweat glands, and oil gland, which is also known as the sebaceous glands. And as we go through this PowerPoint, I also note that there are two main categories of sweat glands. They're called eccrine sweat glands and apocrine sweat glands, which basically literally produce two different types of sweat. Okay, so when you look at your skin, the topmost layer of your skin, which is basically, again, the layers that we're touching, that's your epidermis. The other 80% of your skin, which is this thick layer with a lot of things going on inside of it, is called the dermis layer or dermal layer. And then underneath that, what you see that looks like blobs of fat in yellow, that's a layer that is not technically part of the skin, but sits underneath the skin, called hypodermis or subcutaneous layer. So again, break down the word for yourself, Scott. Epi means what? You guys remember? On top of, correct. So epidermis means top of the dermis, literally sits on top of the dermis. Then you have dermis, and then hypodermis means, hypo means below, right? Correct. So hypodermis means below or lower than the dermis layer. Now, what you see in yellow as these kind of streaks or these kind of bulbous structures right here, these are the nerve ending that gives you basically your sensations. All of the sensation, including pressure, change in temperature, vibrations, touching different surfaces in terms of smoothness versus roughness. All of these are done by these cutaneous nerve endings. Epidermis is made up of epithelial tissue. What kind of epithelial tissue? We talked about this already. Tell me a specific name, guys. Epidermis is made up of what? Okay, more specific than just a squamous. Is it a single layer? Not simple. Is it a single layer? Is your epidermis one single layer of flattened cells? Remember, guys, what did I say? You are getting rid of the dead skin cells continuously. So if you're getting rid of the dead skin cells, then you have to have more than a single layer. So that's correct. You have a stratified squamous, which means you have many layers of flattened cells stacked on top of each other. A really important characteristic of the epithelial tissue is that they are avascular. If you don't know what that means, it basically means no blood vessels. So I tell you this example, guys. You know how sometimes you cut yourself and then you feel the cut, you see the skin being separated, but there's no blood. That basically means the depth of your cut is only within the epidermis layer. So if there is no blood when you cut your skin, that's a damage to the epidermis layer. If you cut and you see blood, then it's your dermis layer. Because it is what? Vascular. And it's very fibrous connective tissue. Anybody remember what type of connective tissue was your dermis made up of? Those all irregular pattern with a lot of proteins in them, a lot of protein fibers in them. Anybody recall? It was a connective tissue, a form of connective tissue. Okay, it was fibrous, it was dense, but dense what? What's the second word? What were my options? If there was like the regular waves of the water, correct? Or the stormy sea, right? It was the irregular pattern, right? So when we're talking about, make a notation for yourself if you're gonna forget it when you look at the tissue. Epidermis is made up of a stratified squamous epithelia. So a stratified for epidermis, and your dermis is going to be dense. Sorry, my copy is like super slow. Dense, irregular connective tissue. And again, hypodermis, as I mentioned, is mostly fat. It does have a function. It does absorb a lot of the shock. So if you basically, your skin is undergoing some sort of trauma, the skin may get damaged, but that damage might not extend beyond your skin to damage the muscles and other tissues. And then the second thing is anchors the skin to the underlying structures. And it also insulates your body. So there's this fat layer underneath your skin, basically make sure that you don't lose a lot of heat. So I always tell my students, and I think I mentioned this to you guys last time or the first class meeting, when you're dealing with elderly, what you notice is they wear many layers of clothing, even though the weather outside is really beautiful. The main reason is because as you age, you lose that fat layer or the hypodermis, which means you are unable to keep your core temperature because you continuously lose the heat to the outside or to your environment. Any question, guys? Any clarification? Sorry, slow down which process? The loss of hypodermis? Not really. It has to do with aging. Hypodermis loss is just that your body will not be able to maintain the fat where it needs to be. So that's just part of the change. It's slowing down your metabolism, and the fat does not go where it needs to go, unfortunately. Be comfortable with this picture, guys. I'm gonna walk you guys through some of the structures right now to kind of highlight the essential components. So again, we have the epidermis on the top, dermis right underneath. Please note that the top part of the dermis is a layer called the papillary layer. And then the majority of this, which is also, again, about 80%, is the reticular layer. There is a difference between the two. There's the red ones here are the red and the blue lines represent your blood vessels. This structure you see, that's your hair follicle. The little glands that are coming or off of your hair follicle, these are oil glands, and there cannot be sweat glands. Oil glands are the only one that connected to your hair follicle. Only one type of sweat glands are shown here. They're called the eccrine glands. But as I will talk about later on, there's another type called apocrine glands. And then lastly, you have these tiny muscles that are attached to the base of your hair follicle. These are called erectile pili or erectile pili. These are the ones that basically allows you to get goosebumps. So you know when you get goosebumps, all of your hair stands up straight. So these are the erectile pili pulling on the hair follicle, making it go straight. A lot of people say that we use this as a guess protective measure, like cats. You know, when cats are scared, what do? Right? And all of their hair stands up. So they have very strong erectile pili compared to us. But evolutionarily, they said that, you know, people in the Stone Age use this a lot more to make themselves bigger, and they have more hair, so it becomes more of a kind of like a cat response. But as evolution changes and we don't really need as much hair, the erectile pili muscle becomes a lot less as well. There is a significant decline. So the question is, why does your hair color changes to gray? Is because you are losing a lot of the proteins that actually causes the hair color. The main one being melanin. So as you age, the amount of melanin in your skin significantly declines, and therefore causes the change in hair color. Okay, so what do we need to know about epidermis? And I'm trying to take some of the information out for you guys, so it's maybe a little more detail that I want you guys to know. So if there's something that I don't need you guys to know, I'll let you know. So we already talked about that they are a stratified squamous epithelium. We also mentioned that they are keratinized for the purpose of basically being waterproofing your skin. So majority of these stratified squamous epithelium, what are their type? They're called keratinocyte. Keratinocytes are basically these cells. Cyte means cells. Keratinocytes are these cells that produce a protein called keratin. And again, these are the ones that give you the waterproofing characteristics. We do lose millions of them every day. Again, especially if you're taking a shower or you're exfoliating, you're losing a lot more because you're literally getting rid of at least 2 or 3 layers of dead skin cells. Sorry, never mind. I'll mention that later on. The second type of cells you have in the epidermis are called melanocytes. Melanocytes are producing the color pigment I just mentioned called melanin. And without me going into details, because the detail is there if you guys want to learn it, but melanocytes produce melanin, and melanin actually can go to your keratinocytes and protect them from the UV damage. So I'm assuming all of you guys have heard of UV, right? UV rays come from the sun, super dangerous, right? Can cause a skin cancer. So what happens is most of your skin is keratinocytes, and they have genetic information inside of them because they have a nucleus. Now, when you expose that nucleus to the UV rays, the genetic information can be modified or changed, which can cause a skin cancer. So what is the body's solution? It releases a significant amount of melanin, which is the pigment, color pigment. And these melanin literally go into your keratinocytes and form this umbrella over the nucleus of the keratinocytes. And therefore, when the UV light hits this umbrella, it gets reflected. So the nucleus that's underneath the umbrella is protected, which is pretty darn cool. So next time when you go to the tanning booth, or you go to the beach and you want people to have that, beautiful tanned skin, that's really not a good thing. That's your body telling you that I'm producing melanin at a much higher rate. And it's telling you, it's warning you that you're putting your life at danger because you're risking a skin cancer. So don't think it looks beautiful. It actually causes damage to your skin. The other category of cells we have is dendritic or Langerhans cells. All you need to know for them is that they're responsible for immunity. So basically, if you cut yourself, there might be these cells that go and kill the bacteria that is on the surface of your skin and limit the chance of infection. And the cells we already mentioned, the proper terminology for them is tactile or Merkel cells. And these are the cells that give you your sense of touch, the feeling of touch as you basically touch a surface. Now here's the cool part, guys. And I'm just gonna shift you guys to the picture and then we'll come back to this. When you look at your epidermis, which is the outermost layer of your skin, you have 4 main layers of cells. So this is only in the epidermis. We're not talking about the dermis layer, just the epidermis. And these are mostly keratinocytes, guys. So if I'm looking from outside, so if this surface is my outside and this is inside, so my dermis would be here and my outside environment would be up here. What you have is the top layer, which is pretty thick, called a stratum corneum. And what are these cells, guys? Are these alive or dead cells? They are dead, correct, dead or dying. So these are the ones that basically, again, you're washing away every time you do something. The second layer underneath that is a layer called a stratum granulosum. These are when you are packing your cells with a lot of keratin to basically make your skin waterproof. You have a layer called a stratum spinosum. They're kind of spiky. And then at the base, you have a layer called a stratum basal. So if I ask you guys, what do you think is happening at the stratum basal? What would you say? This is the bottom layer of your skin, your epidermis. What is the most important thing that is happening in this layer? Okay, cell production is correct, but the proper word would be cell division, correct? So remember, this is the layer that is gonna make my new cells. And as the new cells come in, what are you gonna do? Push the old cells up. So basically, this is an aging process, guys. Your youngest cells are on the bottom, and they're still producing new ones. And as you go through this stage, when you get to the top, those would be your dead cells. Does that make sense to everybody? Any questions about this? Okay. So let me just kind of go back to.
I have a question. I know it's too long to type. That's why I want to use the microphone.
Okay. Yes.
Earlier on, you stated that the melanin component tells you when you're exposed to the sun, gives you a warning that you are in danger of getting cancer. Is that correct? Did I get that correctly?
It's in a danger of damaging the nucleus of your keratinocyte with a possibility of the damage leading to cancer.
So my question is, are darker skinned people more prone to cancer as opposed to
No, they're less prone.
Skin?
Dark
Based on
skin,
that assumption,
darker skin people have what? A lot of what?
melanin.
So would they be at a higher risk or a lower risk? What is the job of melanin? So what is the normal job of melanin? To protect your keratinocytes, right? So if you already have a lot of it in your skin, the protection is already there. You don't need to add it. So in reality, and I'll talk about the skin cancer, there is a skin cancer where it is really common in white people, but you typically don't see it among blacks because they already have a significant amount of melanin and they already have that layer of protection. Okay.
Thank you.
Yeah, if it didn't have to age. If I think it was Alpha that asked the question. If it didn't make sense, you can talk to me during the break and I can explain it a little bit more for you, okay? I'm not sure, is that the white part you see when you get a deep scratch? What do you mean by the white part, Harry? If you don't see blood and you're still within the epidermis, it may be your stratum basal or spinosum. So that's the easiest way. So you really can't tell how deep you have gone until you put like the sample under the microscope and look at the separation of the layers, basically. If you really cut deep, you will see blood, which is your dermis, not your fat. So remember, if you want to get to the fat, you really have cut through the epidermis and your whole dermis. And that's a really super deep cut, and which I don't want to think about, actually. Regenerations of the cell or have to specific. So regeneration of the cell is correct, but a lot of time people associate regeneration with cells being damaged and you're regenerating them. So it's not necessary that the cells are damaged that you're regenerating them. You are doing the cell division for possibly to replace the damaged cells, but mostly for replacing the dead cells. So I would prefer you using the word cell division for the purpose of either regeneration or basically replacing the dead skin cells. Hopefully that answers your question. So regeneration is a very key word in terms of when a tissue is damaged, but in case of you removing dead skin cells, you don't really doing any damage to the body. It's just a normal process. As you age, those cells die. So that's basically what it means. So if it's bleeding, it means you cut deep enough to go on through your dermis, and if it's not, you're at the epidermis. The question was when you paper cut, if you bleed versus not bleed. So yeah, basically use what we talked about. If there is no blood, it means the tissue was avascular, and therefore we're talking about epidermis. And anything underneath the epidermis will have some sort of blood vessels. And typically, if you see blood and the cut is not open or wide enough or deep enough, then you just cut through your dermal layer. I hope I didn't miss any of the questions. Anucleated means no nucleus. So anytime you hear the word A in front of something, that basically means lack of. So avascular means lack of blood vessels. Okay, so let's go back to our layers. Align what to the production process? I'll let you type and then I'll get back to you. Okay, so when we are looking at our layers again, a stratum basal or basal layer is basically where you have the cell division, either to replenish the cells or regenerate the damaged cells. A stratum spinosum is the prickly layers. Again, there are several layers typically, and this is where you are going to see a lot of desmosome forming to allow the cells to be connected together. So if your skin being pulled, you want those cells to basically have that tensile strength so they don't fall apart. A stratum granulosum basically means they have a lot of granules. There are a lot of spots inside of them. And all of those little tiny blobs are filled with keratin, which is the protein that gives you the concept of water resistance. You don't really need to know all of this detail. So it's just the fact that they become water resistant. You don't need to know glycolipids are actually accomplishing that. And then anything after that is the cells are starting to die off, basically. A stratum corneum, which is the top layer, is again typically between 20 to 30 layers. As I mentioned, anucleated means they have no nucleus. Basically, you get rid of it. There is no need if the cell is dead. They are protecting the underlying tissues. They are preventing water loss. And they are the best protection from allowing anything outside to get into your body. Now, the only thing I didn't mention is the layer called a stratum lucidum. So lucidum means as in lucid, clear. So this is only found in the thick skin of your body. And the thick skins would be basically the palm of your hand, your palms or the sole of your foot. So these are basically the areas that come into contact with a lot of surfaces, and they are at the highest risk of being basically punctured or damaged. So you have another layer of protection, which is a stratum lucidum. So when you guys are listing your layers, if you choose to write a stratum lucidum, make sure you list it as only found in the thick skin. If you choose not to list it, make sure you're labeling that this is your thin skin. So that's the main difference. You want to do the, association. A stratum lucidum for thick skin and a stratum, absence of it would be for your thin skin. I'm sorry, Alpha, I still don't understand your question. Maybe I've been talking too much about everything else that I don't remember what concept you're talking about. So let me go over the lecture. I want to make sure the PowerPoint is, we're moving and finishing it up, and then we can talk if we have time at the end of this. Okay, so let's move on to your second layer. That's your dermis layer. So dermis, again, don't really need to know this information, so I'm just going to draw an X on this. What you do need to know, again, it does contain a significant amount of nerves and blood vessels. So you see bleeding, there's a lot of pain associated with it. Lymphatic vessels, since I haven't really talked about it, you don't really need to know it. It does contain your hair follicles, as I mentioned, your oil, and your 2 types of sweat glands. Now, when you see here, it says papillary layer and reticular. Papillary layer is the one that is directly in contact with your epidermis, and it's typically only about 20% of your skin, or sorry, your dermis, and the other 80% would be your reticular layer, which is what most of the structures will be located. So to kind of highlight that aspect for you, see from here to here, this really thick layer, that's your epidermis. No blood vessels, right? Nothing very visible in there. There is no nerve endings, and that's about it. Now, right here, the area that kind of appears as white with blue dots in them, that's the papillary layer. And then basically this section at the bottom would be your reticular layer, and it continues farther down. It's not that, it just continues farther down. But what I want you guys to see in this picture, does everybody see in the box for the reticular layer the dense, irregular connective tissue that I was telling you? The stormy sea, right? That kind of very irregular patterns of protein going everywhere, right? This is what we're talking about here. See, there is no organization, protein fibers are all over the place. So when you're looking at this, that's an easy way of identifying that. Okay, some of the characteristics I need you guys to know in association with the reticular and the papillary layer is, for the papillary layer, what we identify as friction ridges, and make a note for yourself. This is basically your fingerprints, okay? This is found in papillary layer. The rest of the information you don't need to know. I don't really care about the rest of the information. That's more physiology. So papillary layer, if I said friction ridges or your fingerprints are associated with what layer of the skin, your answer should be the papillary layer. Now, what we also have is your reticular layer, which has 2 main features. What we identify as cleavage or tension lines, and what we identify as flexure lines. I want to just kind of show you this. So if you guys look at this picture, and all of you guys have heard or maybe done this before, you know, when you go to a palm reader, right? What do they actually read is the lines that are formed at the palm of your hands. What these lines actually are called flexure lines. And these are the area where the skin actually connects to the bone underneath it. So it's kind of an anchoring point for the skin. And there are actually literally visible marks on your skin, which we refer to them as the flexure lines. So the rest is up to you. If you want to believe, you can read your future about them or not. Cleavage lines. Cleavage lines, what you see are these are not real lines. Like, you can't see these on yourself. It's like, oh, I don't see these lines on my body. You can see them. What they depict is the pattern of your protein fibers in your body. So if you're looking at the collagen fiber, a lot of the collagen fiber in your midsection are going parallel or horizontal, I guess I should say. When you look at your knee, they're also going horizontal. Why is that important? So if you imagine you'll require a surgery, okay? If a surgeon, let's say, wants to cut here, is it better to cut going downward or going horizontal? What do you think, guys? Horizontal or vertical? Horizontal. Why is that? Why do I want to do horizontal? What are you limiting if you cut horizontal? So it does follow the cleavage line, but why does that matter? Okay, I follow these lines of protein fibers direction. Why is that important for me? Not for resistance. So imagine, what's the most important thing after surgery, guys? So repair isn't the right thing. Healing, correct. You want to heal fast. So imagine you have your protein fiber going that way and you cut on the same direction. Have you damaged a lot of protein fibers? Not really, right? But if I go and cut across, then I'm going to cause a lot of damage to all of those protein fibers and therefore increase the chance of, increase the time of recovery. So a lot of my students are, well, you know what, I had this surgery and the cut doesn't match it. Now, it's just not because we have these lines, that doesn't mean we're going to be able to cut on the same direction. But if the physician has the option to cut on those lines or parallel to those lines, they will choose that because it makes the recovery for the patient a lot easier. But in many cases, the option, the type of surgery that you're doing doesn't allow you to make those type of incisions, and therefore they have to cut parallel to it. But if they do have the option, they always try to go with the cleavage lines versus perpendicular to the cleavage line. Hopefully that makes sense. The light bulb gone off. Okay. So another thing that you may see is stretch lines and blisters that are associated with your skin. So blisters are typically associated with some sort of trauma that is literally, if this is my epidermis and this is my dermis, it's allowing these to rub against each other and eventually allow these to fall apart from each other. So there is now a gap between your epidermis and your dermis, and that space is going to be filled with fluid, and that's what a blister is. If you have, on the other hand, significant stretching of the skin in a very short period of time, which is the best example is during pregnancy, or when a person gains a significant weight in a very short period of time, both of these causes the skin to stretch very rapidly, doesn't allow the skin to have the time to actually make more cells to match the rate of the growth. And therefore, the protein fibers that are inside the dermis literally fall apart or pulled apart from each other. So that's where it leaves those basically what we identify as stretch marks. Now, there are a lot of products in the market that may help people get rid of those stretch marks or make them less visible by helping the collagen fiber recover and basically regenerate the damaged tissue. It's typically not 100%, but a lot of people have success with using the stretch or the proper creams to increase the recovery and healing process of the stretch marks. And by the way, what is that, butterscotch? Is that butterscotch? I don't know what is it. The buttercream that they put for the stretch marks before, like during pregnancy, that doesn't work, sorry. Cocoa butter, is that cocoa butter? I don't know. It doesn't work. So sorry to ruin it for you guys. It does make your skin very smooth, but it doesn't really do anything in terms of stretch marks. People swear by it, but not really. The stretch marks are not hereditary. You may be at a higher risk of developing them, especially if you are, let's say you get pregnant with twins versus, you know, a single baby, then you have a higher chance of developing it. You may have collagen fibers that are not as strong based on the genetic component, but I wouldn't put too much stock into the genetic component of the stretch marks. No, both male and female can get them. So again, it just depends. The stretch marks are just based on how rapidly the skin needs to stretch to support what's underneath it and protect what's underneath it. So you do see it in women a lot more often because, especially if they have gone through pregnancy, but men, if they are gaining significant weight, in a short period of time, they do also see that stretch marks. Okay, good question, guys. Hopefully you guys are enjoying this lecture more than what we've been doing so far. Okay, hair, some of the functions of the hair, it's shielding skin from sunlight. So again, you already have that melanin component that is protecting your keratinocytes against the UV rays, but hair is an additional line of defense because your hair is basically dead keratinized cells as well. So it produces another layer of protection. It does protect you against physical trauma. Again, not significantly, but there is roles into it. And then protection from heat loss. The more hairy you are, the less heat you lose, which depends if you're in a winter, it's good. If you're in a summer, not so good. Okay, the other word for hair is pili or pili, depending on how you pronounce it. If I say, what is your hair actually made up of? The function is actually very similar to your skin. They're part of the same system. It is just the flexible version of keratinized. So the way their structure is a little bit more flexible. They are produced from an area called the hair follicle, which is basically the part that is built into your dermis. And then they do contain hard keratin, but I should be careful. They do contain hard keratin, but they are also flexible. We also have keratin in your nails, but your nails is super hard keratin, which doesn't really have much of a flexibility. But it doesn't flake off the dead skin cells. Sorry, not the dead skin. The dead keratin cells on your hair do not flake off like what you have in your skin. So just because you're washing your hair doesn't fall off, basically. Your hair matrix is the region where you actually have continuous cell division, kind of like your stratum basal for your epidermis, where your cell division takes place. The matrix portion for your hair is responsible for that cell division. And then erecta pili, we already talked about that. That's the one that gives you your goosebumps. Why the people textures different? There is a genetic component to that, and you also have the way the hair follicle is localized inside the dermis. That's another reason you get it. But typically, if you look at the hair in babies versus adults, the baby's hair are typically more fine. And then when you reach the age of puberty, when you start to have sex hormone in your bloodstream, then the texture of the hair starts to change. And then when you start to age, then what happens is the sex hormone starts to decline, and then the hair starts to become more fragile and the texture starts to change. But a lot of the changes in the texture has to do with the amount of sex hormone you have, either testosterone or estrogen in the bloodstream, and then also genetic components. Okay, so that's what I'm talking about, vellus hair versus terminal hair. Vellus is basically that baby hair. We call it baby hair. You typically see it in children and in some cases in women, versus terminal hair is the one that is more coarse, and you can see it in the eyebrows, coming off of the scalp, under the armpit, the genitalia area. All of these considered to have terminal hair for both genders. And then facial hairs for male is also identified as terminal. Now, that being said, you know how some people have really super fine hair, even as an adult? The main reason is, again, typically genetic component as well as the amount of sex hormone that causes their hair not to basically make that transition. Protection. Pubic hair purpose is protection. And basically we do everything to protect the one that produces the offspring. It sounds really cliche, but that's basically the main purpose. So if I kind of think about it, we lost hair everywhere in our body except the regions that may provide some protection for us. And you know, like the scalp, the eyebrows and the eyelashes, they both protect your eyes against both radiation and sweat and things getting into your eyes. So same thing with the genitalia. Okay, alopecia is when you start to see your hair thins out. So basically you start to lose a lot of the hair. And then what we have is what we call true or frank baldness. This is the one that is genetically inherited from typically the X chromosome. So it comes from the mom. And it typically affects male. So that's where you get the male pattern baldness. And the main reason that you see that is the follicle that where the hair growth actually comes off of, your hair matrix is located. That's the area that starts to shrivel and shrink, and it doesn't really allow you to grow your hair at the normal rate. There are medications or shampoos that can help this process. Nowadays, you just do basically, hair implant. When they go into your scalp and plant individual hairs into your scalps, but your own natural hair, if you do have the gene, it typically will start to happen around the age of 40 for male, sometimes younger, and it will continue for the rest of your life until you lose all of your hair. Why do some people have short hair? I don't know. I don't understand the question. So short hair, I'm assuming it's just because they cut it? Sorry, if you can clarify your question, I would appreciate it. Okay, time is up. Okay, nail is another thing that we have. So nail is also made up of hard keratin. Again, the word hard versus soft keratin, the main purpose of it is that when you want to touch your hair or touch your nail, you don't want these dead keratin cells to just fly off, right? You want to still be able to provide protection, not like your skin. That's where it is important to have the hard keratin. You have a structure on your nail called the nail bed. So if you look at the picture, here is the white portion is your nail, and the white tissue underneath it, that's your nail bed, basically where your nail sits at. Nail matrix, like, remember guys, the word matrix is being repeated. That's the region where your nail actually grows, and that's located right here at the base of your nail. So it is protected by your skin. And then around your skin, this little skin that is right here, and then it continues and comes off of the sides of your skin, that's called the epinicium, or better known as cuticle. So this is the area that basically the skin that protects the nail bed and then continues and comes off of the sides. So that's the one that you guys got to be careful, because if it grows and you pull it off, it can actually cause infection on the side of your nail. A lot of times I tell my students to do keep in mind that a lot of our medical conditions can actually be diagnosed through your nail, because when you nail and hair actually, and your skin, because especially if you have low protein levels, it causes the keratin level to significantly decrease, and that actually causes your nail and your hair and your skin to become super fragile and dry. So that's an easy way of identifying when you have shortage of proteins or specific amino acids. Does that mean yes, typically when your nail matrix is damaged, that means that nail will not be able to grow anymore. Correct. Anything about, same thing when we talk about the hair growth, if the matrix is damaged, or if you're talking about the stratum basal for the epidermis, All of these means that when they're damaged, you lose the ability to effectively complete cell division and replace the dead or damaged cells. Okay, sweat glands. I'm going to briefly go over this, guys. There are two types of sweat glands or sudoriferous glands. One is called apocrine, and the other one's called acrine glands. So when you look at the acrine gland, which is also called merocrine glands, they are important for the following. They are important for thermoregulation, which means what? Thermoregulation means what, guys? Anybody? Come on, it's an easy one. Okay, controlling your temperature, correct. So I get different answers, so I'll put them together. Control of the temperature, yeah. Thermo means temperature, regulation as in regulating. So thermoregulation is basically regulating your temperature. So when you think about acrine glands, they're the ones that are gonna produce the typical sweat when you're hot. What is it? It's 99% water, and it has a little bit of salt, vitamins, antibodies, and metabolic base like urea and uric acid. But this type of sweat doesn't typically smell. So you're gonna laugh at me, but typically, and this is the way I talk to my students. So you know, like you've gone out in a hot day and you sweat, and then you come back, okay? When you come back, you really are, you come back to your house and you sit down on your couch to rest, and then your sweat evaporates. You typically don't have a bad smell after that. So you just basically, and again, I said typically, some people just do. So when this type of sweat is produced, because it's mostly water, it doesn't really create a bad smell. So when you're looking at apocrine, on the other hand, apocrine, in addition to having everything else that I mentioned, which is the water, salt, vitamin C, and the waste, it contains fatty substances and proteins. So when it contains fatty substances and protein, it gives the sweat a kind of a yellowish color. And this type of sweat glands are not all over your body. They are localized to the axillary, which is your armpit, and the genitalia area for both sexes. So what happens is when you get super excited, or I guess when you reach puberty, when you get excited or anxious, either scenarios will causes the apocrine to release the sweat, okay? So you release this kind of yellowish sweat. And then the bacteria that are present on the surface of your skin start to chop down these fatty substances and proteins. And that's where you get the bad smell. So I want to be clear, guys. The sweat that you produce, the apocrine sweat that you produce, is not a smelling bad. It's the bacteria getting hold of the fatty substances and proteins that makes the sweat smell bad, okay? And again, when you go and exercise, you come back, the sweat, the purpose of the sweat is thermoregulation. As in when you're hot, your body regulation, it helps you cool down your body. That's what thermoregulation means, going back to the earlier question. I'll talk about the location just a minute. But when we're talking about you getting excited or anxious, like you're going to a job interview and you raise your armpit and it smells really bad, that's because the apocrine are producing sweats, and then that's broken down by the bacteria to create the bad smell, okay? So some people say that's associated with, you know, pheromones. I don't know if you guys are familiar with pheromones, to attract the opposite sex. So that's, a lot of people say that's associated with that. I don't know if there is a truth to that, but there is literally a few major differences between acrine and apocrine. First is the location. Acrine are all over the body, versus apocrine is located within the axillary and genitalia. the components inside are identical with the exception of the apocrine having fatty substances and proteins. And then the reason behind why apocrine smells is because of the bacteria breaking down those components. Maybe, I don't know. I said some people say it's pheromones. Yeah, I don't know if I want to smell that. Yeah. Thank you guys. Oversharing. You do know that the rest of the class do that too, right? Just saying. Okay, really cool fact, guys. What we identify as ear wax, so basically what's produced in your ear canals, is actually coming from a modified sweat glands, or apocrine glands more specifically. It's called ceruminous glands that basically produce the ear wax. In women, when they start to produce milk, the milk that comes from the mammary glands, so basically the breast, are also apocrine glands. So kind of imagine, it blows my mind every time, guys, that you have similar type of gland that produces sweat, which is completely different from your ear wax, which is completely different from the milk produced for the babies, right? Mind-boggling. It's awesome. Sorry, I get geeky sometimes. Okay, so sebaceous gland. This is kind of, I guess if you were in, as a teenager, it might be interesting for you. Sebaceous glands are typically inactive in children until you reach the age of puberty. They're located at the base of your hair follicle. I showed you the picture before. And when you basically reach the age of puberty, when you start to produce either testosterone or estrogen, depending on your gender, you start to produce oil gland and release that to the surface. Most of the oil or sebum that is produced contain bacterial killing components that basically helps clean your skin. Now, if you don't wash your skin and you basically block the passageway for the oil to be released to the surface of your skin, you're trapping that oil underneath your skin. And that causes what we identified as a whitehead. Whitehead, if it takes a while and you guys didn't do anything with it, it's eventually going to be oxidized, which is a chemical reaction. And it's going to change to blackheads, which are really feel good to push. Now, if you have dealt with acne, basically what it is you have those whiteheads. And what is whiteheads contain? Lots and lots of oil. Oil is fat, right? It's something delicious for the bacteria that are living on the surface of the skin. So they start to eat the bacteria as a source of nutrients. Now, the interesting thing is your body will notice that and it start to create an inflammatory response, which is basically an immune response. So when you're dealing with acne, basically is an infectious inflammation because the bacteria on the surface is consuming the oil and your body is trying to deal with it. There are medications nowadays for acne that are pretty good that helps keep the inflammation under the control and therefore keep the acne under control. So we already talked about this. Okay, 3 types of skin cancer. So a couple of things that I mentioned before. These are time. Okay, good, we have time. So skin cancers, a few things that I need you guys to know is first when you use the word benign versus when you use the word metastasized. So benign basically means it's not harmful, it's not cancerous. And then if it is cancerous, it can spread to the other parts of the body, which means we're going to use the word metastasize. You are at a higher risk if you basically overexposing yourself to sun that has a significant amount of UV rays, and then frequent irritation of the skin. So a lot of people that works with chemicals that can also cause skin cancers, or if you're in an environment that you're exposing yourself to significant amount of X-rays, that can also lead to cancer. other environment that have high level of pollutant or carcinogens can also lead to skin cancer. Now, there are 3 different types of skin cancers. And you basically, if you want to get a skin cancer, and it sounds really horrible, but if you want to get a skin cancer or carcinomas, basically, your best chance is basal cell carcinoma, okay? Your worst chance is, or your worst chance in survival would be melanoma. So let's quickly look at each of these. So basal cell carcinoma is the least malignant of the 2. What it is basically, when you expose your skin to the sun, the sternum basal layer in the epidermis, the one that does cell division, gets invaded. And if you don't basically treat it, then it starts to expand to the dermis and the hypodermis, the layer underneath it. Really, really good thing about basal cell carcinoma. It is extremely common. It is metastasizes super slowly. So it takes literally years upon years for a basal cell carcinoma to lead to an actual cancer that has a spread to the other parts of the body. What it looks like is these little tiny pink domes. And all you do is literally you go to your dermatologist and they make a tiny incision, they remove it, they put a bandage on it, and you're good to go. That's it. You don't really need to take long-term medication. You don't need to, go under chemotherapy, radiation, etc. That's it. This type of cancer is really common in people who have very fair skin tone and are in a high exposure to sun. So basically, if you have very little melanin in your skin, you are at the highest risk of developing basal cell carcinoma. Second type we have, which kind of looks scary too, kind of look like scaly red patches on your skin. This is the second type, called a squamous cell carcinoma. This affects the layer of the epidermis called sternum spinosum. Now, this is more dangerous because it can metastasize rapidly through the rest of the body. So there is a danger of this cancer showing up in other parts of your body. What's the way for us to treat it? It can be treated with both radiation and removal of the cancerous tissue surgically. If you catch it on time and it hasn't spread to the rest of the body, you have a really good chance of surviving, basically. So it's not too bad, right? Most dangerous one, which is the one you have to be really super careful, and I always tell my students to watch yourself, is melanoma. Melanoma has nothing to do with your skin tone, first of all. Everybody can get it. It randomly starts. It has nothing to do with sun exposure. Even though people who might have sun exposure are at the higher risk for it, but that doesn't mean say, oh, I'm stuck at my home, I haven't gone anywhere, I always wear long sleeve shirts, I'm never gonna get melanoma. That's not gonna be the case. You're still at the risk of getting melanoma. Why is melanoma so horrible? 2 main reasons. First, metastasizes super rapidly to the rest of the body. You don't really think about a skin cancer as something that can cause havoc in your body, but this can, and it's very unfortunate. The second one, it's very resistant to the typical treatment for cancer. So it is resistant to chemotherapy. You can do treatments by literally surgically removing the melanoma and then do things called immunotherapy. But typically, if you ignore these moles on the body, you may actually have a chance that you have metastasized cancer in the rest of your body. What are you looking for to increase your chance of melanoma is early detection by following the ABCD rules. Look for a kind of a symmetrical pattern. So basically, it's not that kind of like round mold shape that people see. So it has different borders, border irregularity. So you have areas that are kind of the areas that are bumpy. So you do have that difference. Colors, they range from brown, black, tan, red, and even blue. It's not like blue, aqua blue, but a bluish tinge to it. And then diameter, look at this, guys, larger than 6 millimeter, which is the size of a pencil eraser. It's not that big, right? But imagine something so small on the surface of your skin can literally cause death. So I strongly recommend to all my students to take this seriously. If you do have a mole on your skin and you see it kind of growing rapidly as you kind of observe it, please go ahead and check it. Worst case scenario, your doctor says you wasted my time, it's just a mole, right? But your doctor will never say that. But it's better for you to check it than to just let it sit and God forbid it be melanoma. Again, just because you have a darker skin tone, that doesn't make you not susceptible to the melanoma. You are still at risk. Can I answer any questions about the skin cancer? We went from like happy thoughts to like depressing thoughts. Sorry. Honestly, I am a big supporter of long sleeve over the sunblock. If you go and if you get a chance to read about sunblocks, the typical sunblocks, not the ones that have, I always forget that. I'll check it and I can let you guys know later on during break. The one that use heavy metal, which are the typical sunblocks you can fly from a department store, and the cheap ones, I call them, even though it costs like $10. They are really dangerous because if you look at how long the components of your sunblock remain in your body, it's so scary. There are ones that can last up to weeks inside your bloodstream, guys. So when you spray that sunblock on your skin, it literally gets absorbed through your skin and go to your bloodstream and is spread through the rest of your body. These are not good things, guys. These are heavy metals that remain in your system. If you're breastfeeding, it can get passed to your kid. It's really, really dangerous. So the next time you're spraying that bottle or rubbing the sunblock on yourself, be careful with it. If you have the option, honestly, I would go with a longer sleeve shirt versus a sunblock. This is from what I read, I literally am against putting sunblock on unless it has that specific component. And I'll find the name where it doesn't show up on your skin. Sorry, it doesn't show up in your blood after you use it. So it doesn't get absorbed to your skin. But there is a lot of times that you put so much sunscreen that it can cause as much damage to your body as much as the sun would do without sunblock. So, and then a good amount of sun exposure is needed for production of vitamin D. That is true, but we're talking about like 15-20 minutes in a day, not, you know, blazing sun with a high UV ray, you know, in the peak of the sun when you go to, you know, a beach where you have really high level of exposure in a very short period of time. So my suggestion for you guys is, first of all, read the components in your sunblock, especially if you have kids, guys. Don't just rub that sunblock on it and say, oh, it's a 80, you know, 80 SPF and it's gonna be super good and they can have it on their skin for 5 hours, nothing's gonna happen. Don't do that, first of all. I usually go with the lower one than the higher number of protection. Those are better for you. Try to wear long sleeve instead of that. And then when you go into the sun, check the UV measurements on online. Typically, I just do Google search, and it tells you if it is safe for you to be outside. If it is safe, then you're good. You can get your vitamin D by exposure to the sun. But if you know you're getting triple the amount of UV rays, then it's not a good idea to go to the sun. Sorry for the very long explanation, but I think it's something that's good for you guys to know, especially if you have kids and you use sunblock on a daily basis. And I go on and found my sunblock so I can tell you what it is. I went and did my research. Yes, weather apps most of the time does tell you the UV rating if you actually pay attention to them. So pay attention to that number. Okay, the last concept I'm going to talk about, and I'm just going to quickly talk about it, is burns. The burns can happen because of typically damage as a result of heat, electricity, or radiation. There are major differences between the burns and the damage. You can literally ignore this section. Okay, so here is first of all how your body is broken down to. So the burns that are in your head, if you have a burn in the face, in the front, is 4.5% of your total mass or total, I guess, body volume. And the 4.5% on your the back of your head. Each of your arms are 4.5% front, 4.5% back. The trunk is 18%, and then each of your legs are 9%, for a total of 18% for each of your legs. And then the genitalia area is about 1%. Now you're like, why do I care about this? Here's what I talk about. Classification of the burn. So we'll come back to those numbers in just a second. First degree burn is probably a type of burn everybody has suffered through at one time in their life. This is when the damage is limited to the epidermis, guys. You barely basically damage the top layer of your skin. You do have localized edema, which is basically swelling of the tissue. You have redness, and you do have pain. Typically, we say if you sit in the sun for too long and you turn that, beautiful red color, that's a first degree burn. Second degree burn, however, is when you see all of the symptoms of the first degree, but the key word here is formation of blisters. So if you have blisters, it means the damage have extended beyond the epidermis and now it's to the dermal layer. Both of these type of burns, first degree and second degree burn, can heal on their own. You really don't need to do anything extensive if you, let's say you burn your hand and you have a blister. If you have blister all over your body, then you have to be something to worry about. And I'll again show you this in a second. Third degree burn is the one that is common in typical severe burns. This is where you burn through both your epidermis and your dermis. This is referred to as the full thickness burn, as in you burning through the thickness of your skin. Skin usually, if whatever is left of the skin is turned grayish white, you have no edema because there is literally no water left to be in the tissue to cause swelling. There is no significant pain immediately after the burn, and it sounds kind of counterintuitive. The main reason is because literally all the nerve endings that were in the dermis were destroyed. Typically, if you're dealing with this, you require a skin grafting, guys. There is no way around that. And these individuals, a lot of them actually die as a result of sepsis because literally you remove the skin, right? And the skin, the job is to protect you. So when you remove that skin, you're exposing that surface to everything that's outside. I don't know if any of you guys have ever had the bad luck of being in a burn unit. It's extremely sterilized because, again, any smallest thing you can carry with you into that area can basically cause the death of that person that has that burn on them. They also, if they're recovering from the burn and their nerve ending starts to recover, they are in significant amount of pain. And for most part, they are going to be basically sedated so they don't have to suffer through the recovery time. Now, here is what I was talking about, the degrees of burn, guys. Burns are considered if 25% of your body is on a second degree burn, which means you have blisters, 25% of your body. If the burn is more than 10% of your body, and it's a third degree burn, it's considered critical burn. Face and hands and feet bear a third degree burn. It's really dangerous, again, because those are the areas that are exposing or the higher risk of carrying infection and causing sepsis. How do you typically treat a burn? You do debridement, which is basically you remove whatever has been damaged as a result of the burn. You apply antibiotics if the skin has been removed. This is for third degree burn. Temporarily covering, and then eventually a skin graft for that individual. So These are, again, what I've listed here for you guys. This is the 3rd degree burn, not 1st or 2nd degree burn. Make sure that's clear. I think that's it that I want to cover with you guys. Okay, did I go over? 2 minutes over. Sorry, I apologize. So I only have 27 people here. So what I would like to do is, I'm gonna read your name. Can you guys unmute yourself and tell me that you are here? Sorry, Guadalupe?
Here.
Melissa? Is Melissa here?
Here. I'm here.
Okay. I'm gonna miss Jose O. Are you here?
Here.
Okay. Ashley?
Here.
Chandra?
Here, Chandrea.
Chandra, I apologize. I literally just wrote a name and I'm like, I don't know if it's the right name or not. I'm not gonna pronounce this, I apologize. Anais. How do we say that?
Here, Anais.
Anais, okay. Veronica?
Here.
Diana?
Here.
Okay. Leah? Not here?
Here.
Okay. Margaret? Margaret, are you here?
Did you say Margaret?
Yeah, Margaret, are you here?
Yeah, I'm here.
Okay, sorry. Wendy?
Here.
Rosa?
Here.
Julio?
Here.
I'm gonna mispronounce this one. Arshwale? Sorry, you told me last time too, but I don't remember it. I think I saw your name there. Lorena? Is Lorena here? Hello? Okay, never mind. Kenya, are you here?
Yes, I'm here.
Okay. Jose P?
I'm here.
Okay. I can't read my own handwriting. Kimberly? Is Kimberly here? Okay, I don't see Kimberly on my list. Okay, guys, I got who is not here. Okay, so you guys are good.
You didn't call my name.
I know. Anybody that I didn't call your name, you guys are good because I found who I'm missing from my list.
Okay.
So you guys are good. Go take your break. Be back by 11:35, and then we'll continue afterward.
Thank you.
Okay, please do not log off, guys. Just to stay on this system. Again, we'll continue with your lab in the same system, on the same Zoom meeting.